Good morning and welcome back to an unexpected fight. We are so excited to be here today with Dr. Schultz, and we're going to have an exciting episode. And Kelly, why don't you go ahead and introduce our guest?
Yes. So today we have Dr. Chris Ann Schultz, MD. She is a pediatric oncologist and Pine Tree Endowed Chair in Cancer and Blood Disorders Research. Dr. Schultz also serves as the Scientific Director of Cancer and Blood Disorders at Children's Minnesota. She graduated summa cum laude from Drake University and summa cum laude from Loyola University. She completed her pediatric residency and pediatric hematology oncology fellowship at the University of Minnesota and received a Master's of Science degree in clinical research during the course of her fellowship. Dr. Schultz is the principal investigator for the International Pleural Pulmonary Blastoma and DICER1 Registry and the principal investigator and founder of the International Ovarian and Testicular Stromal Tumor Registry. Her current research focuses on the development of novel treatments for DICER1 related tumors. She's a member of the Alpha Omega Alpha Honor Medical Society. Dr. Schultz joined the Hematology Oncology program at Children's Minnesota in 2008 and has particular interest and expertise in the care of children with pleural pulmonary blastoma, ovarian tumors, and other rare childhood cancers. So I had the honor of meeting Dr. Schultz at the ASCO conference. We were on a panel together talking about genetic testing. And so I thought this would be a really incredible episode to kind of highlight what she specializes in and some of her research and the registries that she's involved in, as well as talking about the importance of genomic and genetic testing in pediatric cancers. So thank you so much for being here with us today.
Yes. Thank you, Dr. Schultz, for joining us today. I unfortunately did not get to go to ASCO this year, so for me and others who are not familiar with the work that you have, can you share a little bit about your background and what inspired your focus in pediatric oncology?
Oh, thanks so much, Tiffany and Kelly. And thank you, Kelly, for that wonderful introduction. And thanks to both of you for the invitation to talk with you and all of your listeners today about the field of DICER1 related cancers, genetic testing, and rare cancer research. It's really exciting to be able to share that with your broad and passionate and compassionate audience. So thanks so much both for the lovely introduction as well as the invitation. And I would love to share a little bit about the background for me. So starting at the very beginning, I grew up on a farm in southeastern Wisconsin, and just have always enjoyed working with people, which I'm so glad to say is what I continue to get to do now in this role. Then after that, went to Drake, where I studied magazine journalism and biology, because at the time I wanted to be editor of Ranger Rick. I thought, this combination of science and kids and communication has always been really interesting to me. I've always felt very passionately about that. But during my time at Drake, I then did a study abroad program in Tanzania. And actually, I feel like that's just where I fell in love with people and this idea of just working with people directly face to face, which is what I'm so grateful to have found in medicine, in pediatric hematology, oncology, and now in research. So grateful to be a part of this work. But really, this work is about kids and families, which is how it all started, working directly with kids and families on 5B, the pediatric hemonc ward where I did my fellowship, and just getting to know them and their journey. I love it that peds oncology is a whole body, whole family specialty. It's not just about one thing, it's about the whole person, and really beyond that, the whole family and the whole community. I think that's a really neat part, which brings a lot of joy on, the best days and really brings some comfort too on some of the hardest days.
Absolutely. So you already kind of answered the why you got into this, and thank you for sharing that. You've been a driving force, obviously, in rare childhood tumor research. I think your bio shows that. What drew you to studying particularly rare and underrepresented cancers specifically?
Oh gosh, well, thank you first for that very kind question. What a lovely question. Thank you. It's really the kids. I mean, the kids that I have taken care of. Every child deserves the best possible treatment for their tumor, not just the best we have available today, but the best treatment that could be available for that tumor. And kids with common tumors deserve that, and kids with rare tumors deserve that too. That's what these kids and families deserve. So I feel very fortunate to be working with so many kids and families as we try to work to make that happen. So many kids and families and so many awesome other collaborators.
Well, I don't think you give yourself enough credit. I think as two cancer moms, we very much appreciate it. We both have daughters who were diagnosed with what would be considered a rare cancer, especially in their age group. And I think that there's a lot of doctors who maybe, might shy away from that because they're difficult to treat and they're hard. And, people in general, that's a very hard field to get into. So we really thank you so much for what you do.
Yeah, especially with a child who could have had a DICER1 mutation. Nora did not have a DICER1 positive cancer, but ETMR is one that can be driven by DICER1. So it's super important to me, all the work that you're doing too. So let's talk a little bit about genomic testing and tell us about why genomic and genetic testing is so important for pediatric cancers.
Oh gosh, that's a really great question. So when I think about genomic testing, I really put it in 2, if not 3 categories. I think about things like germline testing or predisposition testing. I'm trying to understand the person in whom this tumor developed. And sort of that category 1, we can think about germline predisposition to cancer. Is there any identifiable genetic reason why this person may have developed this particular kind of cancer? And then how can that information potentially help us take better care of that person as an individual, but also better care of their family and their other relatives, even very distant relatives potentially, as some of this research that I'll talk about has shown. So sometimes that germline information can also tell us more about the tumor itself. If we know more about the person, we often can understand more about the tumor itself. There's kind of a variation on that. I'll put that in kind of that category 3 about pharmacogenomic testing. So that falls under the category of understanding something about the person in whom this tumor arose that can also help us understand how best to treat someone or how best to dose their medications, things like that. So germline testing, which very broadly includes things like cancer predisposition or tumor risk, but also pharmacogenomics in terms of how we treat tumors, specifically in terms of how we choose or dose medications. And then separate from that category, we have somatic testing. We have actually testing the tumor itself. And these are, of course, related categories. There's a Venn diagram here, right? But when we test the tumor, we can learn some additional information about what changes in the tumor may be tumor specific, so different from the person in whom the tumor arose, and importantly, what does that tell us about the tumor and how can we treat it better? So I think those two or three, depending on how you want to think about the pharmacogenomics there, those 2 or 3 categories of genetic testing can really help us think through when to test someone and what the utility of such a test might be.
Well, and that was going to be my next question, which being on the panel with you, I already know this answer and how we both feel about it. But for our audience, when do you recommend testing at diagnosis, relapse, survivorship, all of the above?
Yes, such a good question. And yeah, I bet you do know my answer from our time on the panel together. So I think there's lots of different roles for genetic testing, kind of alluding again to those categories. So there's things like testing for why did this tumor develop, or is there anything we might know about this person that may better help us understand this tumor? And that testing can be done actually very early on in somebody's cancer journey. And then those results, those germline genetic results, the sequencing of your DNA, for example, those results then, or the sequencing data at least, hold steady throughout your lifetime. Our germline DNA does not change really in this kind of context. So that those results may be reanalyzed over time, or we may know better what to make of something like, let's say the initial genetic testing shows a variant of unknown significance, a test result we don't quite know what to do with yet in a particular cancer predisposition gene. Well, as more information evolves, we can go back and we can try to reinterpret that gene. And we're involved in some of those efforts for DICER, where we try to say, okay, this is currently a variant of unknown significance, but if we keep working together, we'll develop enough information to then classify that gene into this unlikely to cause a trouble, or that actually may be related to this tumor type or some other tumor type. And so we want to know about this as we go forward. We want to track this as we go forward. So those results then kind of hold steady with room for reinterpretation as time goes on throughout someone's journey. The somatic testing, though, the tumor testing, depending on the tumor type and the treatment strategy that's being employed, there can be a role at multiple different time points to test or retest that tumor. So for certain tumors at diagnosis, it can be helpful right out of the gates to understand as much as we can about the DNA or the methylation or the RNA landscape of that tumor, the fusion landscape of that tumor. And so we may want to know that information right off the bat. Not every single time do we need that information right at the very beginning, but it's often helpful. I do feel really passionately, though, that at recurrence, there's very often a role for either the first time testing, if you haven't done it already, or repeat testing of that sample to see what changes may have evolved or what we might understand now about how to treat that tumor. And the treatment landscape, the options that somebody may be looking at may be very different at that later time point that they were at the beginning. And all of that really is patient specific. It depends some on how much time has elapsed. It depends some on which tumor type, of course. But I think just to say out loud, there can be a role for repeat somatic tumor testing at many time points throughout a patient's journey, depending on how things are evolving for that individual patient, that individual treatment journey. Whereas for germline genetic testing, your DNA really does stay fairly steady, but there's a role for reinterpretation of the testing that was sent, depending on what was initially found and truly how science evolves, which is a big part of why we're here, is to try to drive that forward.
Right.
I love that. So, yeah, I think you touched on this just a little bit, but what do you feel like the role is for testing in treatment decision making, especially in like targeted therapies and clinical trials like the DICER1 trial that you have spearheaded?
Yeah, so I think it certainly depends on tumor type. But for certain tumor types and for certain tumors which express certain either fusions or other genetic changes in the tumor, we really do have some evidence for then what that means for treatment. And so I think for certain tumor types especially, or in individuals who have relapsed or refractory or recurrent disease, I think there's definitely a role for tumor sequencing to try to understand as much as we can about that tumor and what the options may be.
Absolutely. How can families advocate for testing if it hasn't been offered or maybe discussed by their care team?
Well, that's a great question. I think as in so many things, communication is really key. I'm bringing it up, I think, with their primary oncologist and saying, hey, I've learned about this. And do you think this would be helpful for my individual tumor type? And in a lot of situations, I think the answer will be yes. And in situations where for some reason the answer may be no, then trying to understand why that person is thinking about it in that way, I think can really be helpful. I mean, again, for some tumor types right at the very beginning, some testing is being done. Cytogenetic, a great example might be acute lymphoblastic leukemia, where cytogenetics are being done to guide risk stratification right off the bat. And that's just kind of standard, and that's how we approach these things. But in other tumor types where we have less data, there's a bit more variability there. And so trying to understand the decision-making process on both sides, the parent, advocate, guardian, caregiver side, as well as on the care team side, to try to understand, if not, why not, and what are the limitations, and how can we overcome them together if we need to, or how can we pivot to make the best plan?
Absolutely. And I love how you discussed, not only testing in the beginning, but possibly throughout treatment or even into survivorship, because that was something my daughter's geneticist laughed at me when I reached out after 5 years and said, can we redo testing? I know you've learned a lot in 5 years. And they said, thank you for reaching out, because these survivorship patients who, fortunately, we are having more and more children make it to that survivorship, which is wonderful. But those kiddos tend to slip through the cracks when it comes to retesting for genetic components and things like that, because we look at them as, oh, they're doing so well, but there may be things we can learn from them that could help them in the future or other patients. So any families that are listening to this who are maybe in that survivorship category who think, when is the last time we had any sort of genetic testing done? It's worth discussing with your team. I think it's a good conversation to have. And you may or may not learn more about those variants of uncertain significance.
That's such a great point, Kelly. I love the idea of thinking about this in a survivorship context as well, because just as you said, this information really does evolve. And I guess I sort of in my earlier answer assumed that at the beginning, very broad sequencing had been done, and that's not always the case. If we go back, 10 or 15 years, that kind of broad scale sequencing that we might do for somebody at diagnosis today, may or may not do for somebody at diagnosis today, wasn't really even available or feasible logistically in most contexts 10 or 15 years ago, for example, or in some situations even 5 years ago. So saying, okay, maybe I was tested for these 1 or 2 or 5 genes before, but now what's available, and do we need to go back and relook at those options? So that's a great point. Really, I think even putting on your calendar for every couple of years to say, okay, what do I need to know about genetics today,
Right.
that may not have been known by anyone even a couple of years ago, I think can be really important. Just some sort of trigger to help people think about it at regular intervals. And survivorship visits are a great example of that. But there's a lot to cover in those visits. So just making a note to really bring that up and talk it through. Genetic counselors are some of our greatest advocates in this work to help families and healthcare providers understand logistically what are the feasible options to have any individual or any family tested, given what their unique medical history may be. So yeah, I definitely cast a strong vote for bringing it up in survivorship visits and considering meeting with genetics and genetic counselors, as well as your pediatric oncology team.
Absolutely. I hate that a lot of people offer like single gene testing because around 10% of variants are going to be missed from single gene testing whenever you're looking for something and you only find, if I'm only looking for a DICER1 and it's negative, well, what if, all of these other known drivers get missed and looked over, or we're not associating a type of cancer with a certain gene because we're not looking for it. So I think that always I would recommend panel testing versus single gene testing for germline anyway. But
I think a lot of geneticists out there would agree with you.
Yeah. And, obviously I have a lot of discussions with GCs about genetic testing. I have a lot of these conversations with GCs about, well, the families only want to know this one thing, but it's like, well, they think they only want to know that, but sometimes it's important for treatment decision making to know some of these other results too.
Yeah. Tiffany, I didn't know that about you. You definitely bring a unique perspective to that discussion as both a parent and as somebody who works in that area professionally too.
Yeah, and I was an oncology nurse practitioner for 14 years. I worked in oncology, but as a practitioner for 8. So yeah, I have a lot of weird, unique experiences with testing. So, but what do you feel
important
like
perspective? I think you call that important perspective.
Yeah. What do you feel like is barriers to genetic testing, and how can we address some of these barriers that you see in practice?
Gosh, that's a great question. I think one of the ones, especially early on, can be just time. There's a lot of things happening at the beginning when someone faces a new childhood cancer diagnosis, when that patient, when that healthcare team, when that family is trying to get everything lined up for treatment. So I think right at the very beginning, time is often a barrier. I think that cost and the logistics of what's covered and what's not, and how to navigate that, and what that means for what kind of testing can be sent, those are very real barriers that we have to work to overcome. And I also think we're still relatively early on in our understanding of some of the facets of this testing. And so sometimes we do get back variants of unknown significance, and we have to say, okay, we're working on it, but we don't know whether or not this particular genetic difference between you and some other people is a meaningful difference, a difference that confers risk or that might influence health outcomes for you, or whether it's just different than somebody else's, but it doesn't actually cause any sort of issue or change in the way that the gene works or in what we might expect for an outcome for that person. So I think it's a multifaceted, many layers of barriers, really. But I also think these are overcomable barriers. I also think that if we continue the conversation, if we keep collaborating together, we can really knock off each one of those barriers. Not even just one by one, but kind of work on a little bit of each of them all at once. So that people really can get the testing that they need for an individual situation. And of course, still lots of room to individualize things for each individual patient journey. I don't think there's a one size fits all necessarily for each patient or each family. I mean, as you said, Tiffany, there's differences in what people want to know or what they perceive to be helpful versus harmful that we should take into account. We need to take, of course, the individual medical situation into account. There's lots of different things to consider. But most of all, we want to try to break down the barriers so that when testing is the right thing for an individual or family, they can access it. And ultimately, that we understand what that testing means for them as best we can. And working together is the best way to get there.
Yes, I love that.
Platforms like this hopefully will help a little bit. That's our goal anyway. So You have done groundbreaking research around DICER1 mutations. Now, Tiffany and I are happy to say we have a variety of different listeners for our podcast, from researchers to family members. So some might not fully understand or be familiar with it. Can you explain what DICER1 is and how it's linked to pediatric cancers?
Oh, thanks, Kelly, for that great question. So DICER1 is really a key gene in human development. And if you think about how it functions, it almost functions like a dimmer switch on cell growth and proliferation. So it regulates these microRNAs that ultimately influence cell growth and proliferation. So it's perhaps not too surprising that if one copy of DICER1 is out, then someone may be impacted by a condition like tumor development, which is related to cell growth and proliferation. So what we understand now about DICER is that if someone has one copy of a DICER1 gene, often but not always inherited, that causes that gene to not produce functioning DICER1 protein, then they're at increased risk for a certain set of very specific tumors. You mentioned PPB earlier, Kelly, which is, while rare, is the most common lung cancer of infancy and early childhood. So pleural pulmonary blastoma is kind of the sentinel, very uncommon otherwise tumor that was first discovered to be linked to this gene DICER1. But we now understand really DICER1 to be linked to a wide variety of other very specific tumors, including a tumor called ovarian Sertoli Leydig cell tumor, certain kinds of kidney cancer and benign kidney tumors as well, cystic nephroma, the benign version, or anaplastic sarcoma of the kidney, a subset of Wilms tumor, a very common kidney tumor. Well, all childhood cancers are rare, of course, but within the rarity of childhood cancers, we have certain more common tumors and certain more rare tumors. Wilms tumor is among the more common, and a small subset of Wilms tumors are DICER1 related. We also see thyroid nodules and thyroid cancer, and thyroid nodules are not necessarily cancer, and like in that same vein, lung cysts, which are not always cancer either, are also seen in individuals with DICER1. So a wide variety of different kinds of tumors. Some of them are categorized under sarcomas, some not, that we see in individuals who have these tumors. Or who have this gene difference. I'll also say, and I think it's important to know that not all DICER1 cancers arise in someone who has germline DICER1. So about 40% of ovarian Sertoli Leydig cell tumors, for example, arise in someone who doesn't have any identifiable predisposition to a DICER1 cancer.
Thank you for that explanation. This is why I brought you on today. You're very good at breaking it down for people, and I love it.
Yes, I love that too. So, you're the Principal Investigator for the International Pulmonary Blastoma / DICER1 Registry that was started in 2016. Can you tell us about the impact that is having?
Oh gosh, thanks so much. Well, first I want to start by saying that the International Pulmonary Blastoma Registry, which is what it was called when it was first started, was started in 1987, and we stand on the shoulders of giants. There are so many people that have brought this research to where it is today. I want to credit Dr. Yoav Messinger, Dr. Ashley Hill, Dr. Jack Priest, Dr. Pepper Daner, Gretchen Williams, and really so many other people that have really laid the groundwork for where we are today, as well as our current team, who's just doing such great work. I'm so proud of them. So our current team includes our clinical research specialist, Ann Harris, our clinical research coordinator, senior clinical research coordinator, Paige Mallinger, as well as Anna Divick, Brenny McNally, Melissa Abraham, and Alex Nelson. So just a wide variety of people in our Minnesota-based team, as well as this wide wide network of collaborators from institutions across the world that really advance this work that I'm so excited to talk with you about. So lots of people working together to make this happen. But our current efforts are really directed toward these 4 strategic pillars of understanding, based on what we have today, how can we best treat individuals with these conditions, kids and adults with these different conditions. So given what's available to us now, what should we do? That's pillar number 1. Pillar number 2 is really about early diagnosis. So we just recently published surveillance guidelines, which I'm hoping to spread the word about during today's podcast. So those hot off the press surveillance guidelines saying, okay, if you're identified as having this risk for development of these DICER1 related cancers, what next? At what intervals should you or your child, if they also carry that risk factor, should they have a chest x-ray or an abdominal ultrasound or a pelvic ultrasound, those sorts of things, thyroid ultrasound. So pillar number 2, early detection. Pillar number 3 is, okay, based on work, we've recommended these surveillance guidelines based on what we have available today, but are there any better ways to diagnose these tumors, either fresh as surveillance or early detection of tumors that have come back, for example, when they still might be surgically resectable. And then pillar number 4, which I feel so passionately about really, is novel therapies. So how can we take what we're learning from cell lines, from patient-derived xenograft models, from organoid models, and turn that into novel therapies, which could then become available for children and adults with these cancers. So really this 4-prong approach, I do try to boil it down to just 2. If I were to pick just 2, I would pick, we're all about early detection and novel therapies.
Yes.
So there's the 4-word version. But really those 4 pillars are what we're all about. And really, I'm so grateful to say making progress in each of those areas.
That's incredible. You should be very proud. That's a big undertaking. But it's, we always talk, Tiffany and I have talked multiple times about how important registries can be in this world, and being able to kind of share that information with researchers across the country and out of country, other countries. So it's really amazing to speak with someone who's doing just that. So you talked about the tumors or syndromes that might be associated with DICER1 mutations, but how might early testing change the outcomes for these patients and families? And are there any specific success stories or discoveries that you're particularly proud of?
Gosh, that's such a great question. I mean, to me, early diagnosis is such a key part of this. So pleural pulmonary blastoma, that infant lung tumor, infant toddler lung tumor that we talked about, that progresses through these 3 main types. Type 1, which has a thin layer of malignant or cancerous cells. And if those grow and they continue to make more copies of themselves, you then have this partially filled in, half cystic, half solid tumor, type 2 PPB. And then those cells really get going and you have a purely solid type 3 PPB. If we can intervene at that earliest stage, at that type 1 stage, those tumors are sometimes curable with surgery only, taking out what appears to be the cystic lung lesion. But when you look under the microscope, there's some cancer cells there too. That's really a huge goal for us. And I'm so grateful to say that we've seen that happen, that really if we can identify these individuals at risk, either through family testing or through broad-scale genetic sequencing or through other mechanisms, through their own medical history or the medical history of their family, we can then institute these surveillance guidelines, these surveillance algorithms. And I've gotten to see now multiple times in my own clinic what happens when we do that, which is that we find those tumors then as type 1 PPB when, again, they can be removed with surgery only. So I'm caring for a few of those kids in clinic right now, and I just take a deep breath every time I see them in clinic, and I'm just so grateful for that. And similarly for the ovarian tumors, some recent work published by Alex Nelson has shown that those ovarian tumors, when detected by surveillance, are both require less episodes of chemotherapy. We can sometimes treat those with surgery alone rather than surgery plus chemotherapy, and that outcomes are better, that survival is improved. So I think these are really important things to think about when we think about testing. And from those families really have learned this phrase. I want to credit specifically the family that taught me the following phrase: knowledge is power. That if we know about this ahead of time, it doesn't necessarily mean anything bad is going to happen. Many individuals with DICER lead happy, healthy lives and don't need any interventions at all for tumor development. But if we can identify the subset of people that do have early signs of tumor development and intervene in that earliest, we say earliest and most curable form, I think that's really one of the keys to improving outcomes.
I think we have a hashtag for this episode, Tiffany. Knowledge is power, because it's true. And people do sometimes question, like, why do the extra testing? Why do this? Because knowledge is power. That's a very easy way to put it.
Yep, that is one of our registry hashtags, actually, with full credit to the family, to the amazing, with full credit to the amazing mom that taught me that phrase. Yes, one of our registry hashtags is knowledge is power, and one of them is earliest, most curable form.
I love that.
Yeah, that's good. So, outside of your DICER1 research, we know that yourself and Dr. Harris founded the International Ovarian and Testicular Stromal Tumor Registry in 2011. So tell us a little bit about this and any other initiatives or projects that you guys have going on.
Yeah, well, we first started, Ann Harris and I, together with our mentor, Dr. Messinger, the International Ovarian and Testicular Stromal Tumor Registry, like you said, in 2011. And our goal there really was to understand the underlying factors, including potentially DICER1. It wasn't fully understood at the time. These connections between these factors and ovarian tumor development. And our hypothesis was if we could understand more about that, we could then both influence care for women with ovarian tumors, but also potentially detect these PPB tumors or other tumors in their earliest and most curable form. So really sort of this iterative goal of trying to understand more about ovarian tumors, to learn about these other rare tumors, to go back and influence ovarian tumors. And I'm so glad to say that's really what's happened. So now that we understand more about Sertoli late egg cell tumor and gynandroblastoma, these two rare types of ovarian cancer that we initially set out to study through this OTST registry, we now know that those are related to DICER. So those patients are now offered enrollment on the DICER1 registry. But patients with other tumor types, other sex stromal tumor types like juvenile granulosa cell tumor, for example, are still offered enrollment on the OTST registry. Those are not necessarily DICER1 related tumors, but gosh, we still need to understand more about them. We still need to understand especially how best to treat those tumors. And so we've got some exciting initiatives, particularly around juvenile granulosa cell tumor. Again, not necessarily a DICER1 related tumor, at least in most instances, but so much that can be learned from that. Ann Harris recently published this connection between mitotic index. How rapidly do the cells appear to be dividing under the microscope? We just see still frame, of course, but based on how many mitotic figures we see, what does it look like is happening there? The connection between that index, that mitotic index, and outcome in juvenile granulosa cell tumor. And I think it's an exciting advance and really the first additional step in this risk stratification. And I hope ultimately in understanding which tumors are likely to behave badly, and therefore we need to intervene more, and maybe even in different ways, and which tumors are likely to have a more favorable prognosis, and those folks could potentially be treated with less therapy or surgery alone. So really trying to risk stratify so that you get the right therapy to the right person at the right time.
I think you've somewhat answered this, but you've been a part of shaping national and really international guidelines. What progress have you seen in how the medical community approaches these more rare tumors and genetic predispositions?
Oh, gosh, well, thank you. First of all, thank you. And that's such a great question. I think a big advance that's coming, one that we're really trying to understand as a community, as an individual research group for sure, but also as a larger, broad community, about what leads to these tumors to develop, what makes them different than the healthy tissue from which they arose, and how might we target that? I think that's a national and international conversation right now. So I think that's a big piece of it. And also just this huge global effort. I mean, we're so grateful to be part of these global efforts focused around rare cancer. And I really think that's where the future is. If you just run a study as a single institution or even as a single country, you're not going to get where you need to be with rare cancers. It really has to be not just multi-institutional, but collaborate across borders, across oceans, to really try to understand things at the level you need to understand them, and also at the speed that you need to understand them. If your study is going to take 20 years to understand if this treatment that we have available to us today works, that's not it. That's not the right answer. You really have to build the study so that the results can be useful in real time, because the rest of science is evolving at the same time.
Right.
So I think collaboration is really key to that. And we have to think really broadly about what that means.
It's fascinating to see how the landscape of pediatric cancer collaboration is so vastly different from adult cancer collaboration. Adult oncologists don't routinely sit around and talk about different things. Of course, they do tumor boards and other things like that occasionally, but on a regular basis, I don't think they sit around and talk about different cancer types and what are we going to do for this and how are we going to approach that. And whenever I went to the ETMR summit in Mexico, I think there was 8 to 10 different countries represented there from all of these different pediatric cancer researchers and pediatric oncologists we were literally all sitting in a room, and they're like, somebody would do a presentation, then they'd have a big discussion afterwards, and they'd say, okay, let's look at this and let's look at that, and how we are approaching this, and what can we do different from that, and what were your outcomes when you did XYZ. So it's fascinating to see how collaborative that pediatric oncology is. to work towards improvement, since we really don't have a lot. And I guess that's probably what the vast difference is between pediatrics and adults. Adults, there's so many options, and our kids just don't really have all that much. But what gives you the most hope right now, Dr. Schultz, in pediatric cancer research?
What a great question. I think it's that collaboration that you're talking about. I think that if we all work together, I really do think we're going to get there. And I feel that way for pediatric oncology, for sure, where all cancers are rare, though some more rare than others, but also for the rare cancers that we see in adults, and really even for common cancers in adults as well, that I really think if we all work together, the answer is there. We just have to put the pieces together. And I've learned that from an amazing mom too in my clinic. I called her to ask her if it was okay if I shared the journey of her daughter with this collaborator in Europe that was writing this case series. I said, is it okay if I contribute your daughter's story to this case series? And she said, look, the pieces are all out there, but we have to all work together to assemble them. So not only may you, but you darn well better put the data together with that collaborator. That was her answer. It was great. I just still makes me smile every time I think about it, that, this is what families want. This is what patients need. And this is what we all want, is to find the answer together. And together is the way that we're going to do that. We all want to find this answer together. And that means not just researchers working together, not just clinicians working together, not just families working together, but researchers, clinicians, families, everybody, all of us working together. Because there's pieces of this work that only patients and families can do. And there's pieces of this work that only people with, test tubes and pipettes can do. And there's pieces of this work that each one of us can do, but it's really by far and away the most powerful if we all do it together.
And I think I've said multiple times on this show that I think that somatic testing is the way of the future and how we figure things out, because I started in oncology in 2011. We did like single IHCs for EGFR, and then it was EGFR and ALK, and then it was EGFR and ALK and ROS1, and now we're at these whole exome, whole transcriptome, 20 plus IHC tests to see what drives these tumors. And once we figure out these drivers, then they're developing drugs on the back end to stop the growth or proliferation or, whatever that driver is. We're able to develop drugs. And so I think that testing these tumors is really going to change the way that we continue to treat cancer.
Absolutely. And Dr. Schultz, what advice would you give to a parent who has just been told their child may have a genetic mutation?
I think it's that hashtag we just talked about, that knowledge is power, that finding this information doesn't change, let's say the person already has developed a cancer. It doesn't change that cancer, and it doesn't actually change the likelihood in reality of something happening or not happening in the future. But what it does give you is the knowledge to take the next step. And whether that next step is understanding the tumor in front of you better, or whether that next step is just empiric surveillance because they were tested as a healthy individual with no cancer history, and we're going to screen for those things. I think to remember that knowledge is power, and to take that hashtag. I'm not really a social media person, but here we are, right? To take that hashtag with them as they go forward with these next steps. Again, whether that next step is care for the immediate situation in front of them, or early detection for something which may happen or may not happen. By the way, it's important to know that the genetic diagnosis doesn't mean something necessarily will happen. In the vast majority of instances, it just influences risk of something happening. And then to really use that information as best you can, which usually means sharing that information with other people who may need it. I think those two pieces are what I would say.
Perfect.
That's awesome.
I agree.
Yeah. So what are some of the most important questions you think families should be asking their medical teams when it comes to genetic or molecular testing for their child's cancer?
I think probably opening the conversation. I think that, there's a lot of things to talk about in every visit, right? There's so much going on, especially at the beginning of a cancer journey. And even at those survivorship visits that you mentioned, Kelly, which I think are such an additional great time to bring this up if it hasn't already been completely and thoroughly covered before. I think and even when we think it has, often it hasn't. So continuing to bring it up. So I think opening the door for that discussion, and then as that door is opened, saying things like, are there any tests that you would recommend at this juncture? Why or why not? Or how would that help us? How can we access that? I think just trying to have an open conversation about what would be most helpful in an individual situation, opening the doors to those discussions.
Absolutely, I agree. Now, how can families or patients get involved in the DICER1 registry or similar research initiatives?
Oh gosh, thanks so much, Kelly, for that question. Well, we hope that anybody listening to this who feels called to become involved in DICER1, PPB, sertoli-Leydig cell tumor, or juvenile granulosa cell tumor, OTST, ovarian or testicular stromal tumor research, will contact us. We have pretty easy email addresses for the DICER registry. It's dicer@childrensmn.org for childrensminnesota.org. You do not have to have germline DICER1 to be eligible. The eligibility criteria are any known or suspected DICER1 related condition, and or, doesn't have to be both, germline DICER1 variant, and that includes variants of unknown significance or of uncertain significance. We are trying to collect data for those as well, in the hopes that they might not always be variants of uncertain significance, but that we might be able to put together enough information to guide them one way or the other over time as we learn more. So if this is something that people feel called to become involved in, we do hope that they'll reach out to us. We also have lots of information available online. There's a website for the PPB registry, ppbregistry.org, and for the OTST registry as well, otstregistry.org. We do as best we can to try to share out the results of the research. Like, as we collect this information, we want to share it with those who need it most. That's treating clinicians, of course, and patients and families. So in order to do that, we have newsletters. We have a family meeting and scientific symposium every year. It was just held on May 6th, actually, but we recorded it. So we have those recordings available for people. We do have some presence on Facebook and other social media platforms. Again, just really trying to get the word out, because we, like you, believe that knowledge is power.
So how
We'll
many?
make sure we include those too. We'll make sure we include those in the show notes at the end of the episode. Your email address is the website. It'll all be in the notes below for anybody that's listening.
So do you find that there's a lot of somatic DICER mutations, or are they mostly germline?
So DICER tumors are really interesting in that regard. So most but not all DICER related cancers actually have two changes in DICER. And the first is often but not always germline, and the percentage of that depends on the tumor type. And the second is essentially always somatic. And that's a very unique place. So those somatic alterations, the ones that are always somatic, are in this area called the RNase 3B domain. And so nearly all DICER1 tumors really have this change in that RNase 3B domain, again, with or without a germline alteration, although often, but not always, that's present. And so we can really use that tumor pattern to help interpret the results of genetic testing. And ultimately, we're trying to use that same RNase 3B change to understand what circulating tumor DNA diagnostics might look like in DICER1 related cancers. So trying as best we can to use what we understand about the tumor biology to really drive care. That's a big piece of DICER right now.
That's interesting you bring up the ctDNA. So obviously that's a hot topic these days. How do you feel that that's going to be intertwined into pediatric cancers? Do you feel this is going to be utilized in solid tumors?
I do. I think we've got a lot of work yet to go, but there are some really great people working on this. And so I think it's going to be an important tool in the armamentarium. I don't think it's the only tool we need, but I think it's a piece of the puzzle. And so my goal is that we learn as much as we can from what's being done in other spaces about that. And then we learn how to uniquely apply it to kids with these rare cancers. Again, for earlier diagnosis, ultimately potentially for screening if we could identify the right situation for that, and then also to monitor for tumor recurrence. So in individuals who have an identified tumor, if it does come back, how can we identify that recurrence in its earliest and most curable form, potentially when it's still amenable to surgery or radiation, or certain forms of treatment, systemic treatment that might work better when there's just small amounts of disease compared with larger. So I think there's a lot of really exciting potential there, and that's one of the projects we're working very hard on as well. That's pillar number 3 of the list.
All right, so you gave us a little bit of a hint earlier. You've got something exciting development on the horizon. So what's next for you and your team? And are there any exciting developments on the horizon?
Well, I think for us, one of the big things is development of novel therapies. So we've learned a lot since DICER1 was first described in connection with PPB about the gene itself. We've learned some about the spectrum of different tumors associated with it, and we've made a lot of progress in terms of surveillance guidelines and early detection. But in my mind, the next frontier is really, okay, now how can we take all of that and discover more effective and less toxic therapies for these tumors? So a lot of our efforts right now are surrounding fresh tissue, like if someone's going to have a surgery for what we think or know is a DICER1 related cancer. We're trying to get that tissue then into a preclinical model system where we can test different treatments against it. And again, really try to understand the most effective and least toxic therapies for these tumors.
Absolutely.
That's so great. So we've talked a little bit about how people can stay connected with you. I'm going to link that in the show notes. Is there any way that people can help support your work?
Oh gosh, thank you also for that great question. That's a great one. We would love people to become involved and then to visit the registry. There's lots of different options for how to become involved or how to support the registry on the website link as well. But I think the most important thing I want to leave people with is that this is a team sport. The cancer research is a team sport. So again, people, if anyone listening to this that feels called to learn more about it for their own care or to become involved to help drive it forward for others, or some combination of those things, we would certainly love to connect.
Well,
Thank you so much, Dr. Schultz.
Oh, thanks, you guys. And thanks for all the great work that you guys are doing to advance childhood cancer research and advocacy and really all that you do on behalf of your own kids and so many kids and families around the world. That's so awesome.
Thank you. Well, thank you guys for listening to another episode of An Unexpected Fight. We're so thankful for Dr. Schultz for being on the episode today. If you want to get involved, you can go to goldribbon-kids.org or nationalpcf.org. We'll link our emails in the show notes. And if you've got anything you want to hear about, let us know in the comments. We'll see you guys soon.
Awesome. Thanks so much, everyone.